Hi, everyone. My name is John Doe. I'm one of the diagnostic and interventional radiology residents at the University of California, San Diego. The talk I wanted to give today is on complications of needle breast biopsies. We'll talk about the complications as well as methods to prevent and manage it. I think that it's important to understand not only how to do the procedure, but also to know what sort of complications to anticipate so that we are well prepared and well equipped to deal with them and do best for our patients. So before getting started, I want to sort of cover the medical history of breast core needle biopsies. Back in the late 1970s to 80s, the main methods to obtain pathologic specimens of suspicious breast masses were by fine needle aspiration, or affectionately called skinning needle, or through surgical excision. Now, the problems with fine needle aspiration were that it yielded insufficient tissue a lot of the time, as well as false negative findings. Then in the early 1980s, the biopsy gun was invented. Initially, it was used for prostate biopsies, but then it was adapted for other organs, including the breast. Then in the 1990s onward, there was a lot of literature published by Steve Parker, sort of demonstrating that core needle biopsy was comparable in accuracy and lower in complication rate versus surgical excision. So now we'll talk about the complications. The most commonly reported are going to be pain and bruising, but what we'll focus on are the more severe complications and the complications that may need further management. Now, this is low for core needle biopsies, reported less than 1% of the time, versus surgical excision, which is 2 to 10%. And here's a list of the complications that we're going to discuss. So they're basically going to be organized in the way that I like to do my informed consent, which is basically bleeding, risk of infection, and damage to surrounding structures. So in terms of bleeding, it'll be hematoma and pseudoaneurysm formation, risk of infection, including mastitis and abscess, and then damage to surrounding structures, which can lead to milk fistulas, implant ruptures, or pneumothorax. So here's our first case. The patient had a biopsy and underwent a post-biopsy mammogram, which demonstrated a hematoma. And fortunately, the patient did not notice this. This was only noted on imaging. So we'll talk about the risk factors, methods of prevention, and treatment. So like our case, hematomas on post-biopsy imaging is quite common, seen in 19 to 60% of patients who undergo breast biopsies. Only 4 to 21% of patients will have clinical evidence of hematoma, and only 0.2% will require further intervention, such as drainage or treatment if it is infected. And potential consequences, again, patients may require drainage if they are symptomatic, and it may cause some clip migration in about 25% of hematomas, with a mean migration distance of 1.2 centimeters. And this was mostly described in vacuum-assisted biopsies. Now, in terms of risk factors described in the literature, this is for any hematoma. So typically in malignant masses, which are more vascular, posterior biopsies, where our chest wall arteries will taper more anteriorly, so they are much higher in caliber posteriorly, and if patients are on anticoagulation or antiplatelets, with most of the evidence leaning more towards aspirin, and for larger needle sizes. Now, not found to be risk factors for any hematoma includes the imaging modality used, either stereotactic, ultrasound, or MRI guided, and the number of passes. No risk factors were found in the literature for clinically significant hematoma, which we'll discuss further, and that includes patients on anticoagulation antiplatelets and the biopsy needle size. So just diving into the major literature discussing the risk of bleeding post-biopsy with patients on anticoagulation. So the first large study was published by Somerville and others in 2008 in AJR. This was a retrospective study which studied patient-reported symptoms. Now, in their group of patients, they noted that there was a higher risk of bruising if patients were on anticoagulation. And if you notice here, it is mostly skewed towards aspirin. There's no difference in patients who reported a lump, which they equated to a hematoma. Now, this also prompted a prospective trial published by Chetland and others in 2013 in AJR, where they had both patient-reported and imaging evidence of hematoma. And they spanned a wide variety of different biopsy techniques in terms of image guidance, as well as needle gauge size. And they found that in patients who are on antithrombotic therapy, they noted significantly higher hematoma, but none of these were clinically significant. And again, similar to the prior study, a minority of patients were on warfarin or other anticoagulant, antiplatelet, and most of it were studied in patients on aspirin only. So in summary, non-clinically significant hematoma in their study, which was defined as hematomas which were asymptomatic, seen only on imaging, that were mildly tender, controlled with Tylenol, and also led to increased compression time without further intervention. All of these were non-clinically significant hematomas. Now, this was noticed to be increased in incidence in the antithrombotic group, 21.6% versus 13.0%, whereas no patients in either group were found to have clinically significant hematoma. And the way that they defined clinically significant meant that patients who required surgical intervention or drainage, admission for a hematoma, or short-term clinical follow-up. Also included in their definition of clinically significant hematoma is severe discomfort, not responsive to Tylenol or acetaminophen, and delayed ultimate surgical treatment, perhaps in the setting of a migrated surgical clip. So no patients in either group, with or without antithrombotic therapy, had a clinically significant hematoma after biopsy. So the big takeaways are that in both of these large studies published in AJR, there's no difference in clinically significant bleeding, but there was an increase in bruising and non-clinically significant hematoma on antithrombotic therapy. And again, it was mostly in patients on aspirin. Their protocol, which is important to note, is that it included 5 to 10 minutes of manual compression after their biopsy, which may have decreased the incidence of hematoma formation holding pressure for that long. Additional studies and guidelines, I believe, are needed to address other medications such as warfarin or clopidogrel, which were in a minority of patients in these studies. Now, are there any guidelines to help provide any guidance in terms of lab and medical management before a procedure? Now, the Society of Interventional Radiology had published some guidelines in terms of periprocedural management, and they had listed breast biopsies under low bleeding risk procedures. And in their low bleeding risk procedures, they recommended that labs, the INR and platelet in particular, are less than 2.0 to 3.0 and less than 20 respectively. Now, they don't recommend routine checking of labs, but if patients were, say, on warfarin or were thrombocytopenic at baseline, then they would recommend these goal values. And in terms of medications, the only medications worth noting for these low-risk procedures, including breast biopsies, are warfarin, as well as cangrelor and the glycoprotein 2B3A inhibitors. Now, the last two are typically seen in cardiac inpatients and will likely not apply to our outpatient setting. So the only medication to really keep in mind is warfarin, where they recommend a target INR of less than or equal to 3. So for patients with post-biopsy hematomas, typically these will be managed with just manual compression, 30 to 60 minutes, and or pressure bandage. And patients can be discharged with ice packs or Tylenol to take symptomatically. Injection with lidocaine with epinephrine can be considered to vasoconstrict those vessels. And if the hematomas are rapidly enlarging or there is evidence of active extravasation, then an IR consult for intravascular embolization or surgery consult for ligation can be considered. For our next case, this patient noted swelling immediately post-biopsy. So here we see that the target lesion is being biopsied and placing the ultrasound probe in that same area again, demonstrated a 1 centimeter pseudoaneurysm, which was refractory to manual compression. So the pseudoaneurysm underwent thrombin injection with minimal residual flow. So our next topic is going to be pseudoaneurysm, and we'll talk about the risk factors as well as the management. Pseudoaneurysms are rare. They're limited to case reports. But in terms of their presentation, they can occur during the biopsy or after. And they'll present as persistent excessive arterial bleeding refractory to manual compression. We could also see breast swelling or pulsatile mass. And the imaging features are important. We would see an anechoic structure, such as here, with to and fro waveform on color as well as waveform. And potential risk factors for developing this, and this is based typically on the femoral pseudoaneurysm literature, are going to be age, atherosclerosis, and anticoagulation. In terms of treatment and management, this would be starting off as conservative, and if those methods don't work, then an IR consult or surgery consult. So with our graded treatment approach, starting off with pressure dressing, and then if not, ultrasound-guided pseudoaneurysm neck compression for 20 to 30 minutes. And if that doesn't work, then percutaneous injection with thrombin of 0.5 to 1 milliliters of 1,000 units per milliliter concentration, or absolute ethanol of 1 milliliters. And it's important to perform this away from the pseudoaneurysm neck in order to prevent embolization into systemic circulation. And if those are refractory, then IR consult for endovascular embolization, or surgery for surgical repair and excision, as shown here on the right. So this patient presented approximately 1 week afterwards from biopsy with erythema, redness, and swelling. So this patient was diagnosed with mastitis and treated with oral antibiotics. So we'll discuss mastitis as well as abscess, risk factors associated, and the management. Overall, the incidence is very rare, ranging from 0.0 to 0.14%. In this study by Reisenauer, published in 2017 in AJR, they actually performed quite a large number of biopsies without an ultrasound probe, cleaning in between biopsies with betadine or sanitizing wipes, and laying down sterile towels using sterile gel and sterile biopsy needles otherwise. And in their patient population of 12,000 patients, they had only seen this many infections. So 13 of whom had undergone core needle biopsy and vacuum-assisted biopsy, 0.14%. And in the 3,000 patients who underwent fine needle aspiration, only one had an infection. There was no relationship that they found between needle size or with number of passes, and all presented with erythema, and all were treated with oral antibiotics. In another study, which was a composite of different procedures performed at this institution, published by Cervini in AJR in 2010. So taking just the ones relevant to breast biopsies, we can see that their risk of significant infection requiring intervention or hospital admission was only 0.1%. So overall, just a very rare occurrence of infection after core needle biopsies. In terms of its presentation, as we saw in our case, patients would typically present with focal inflammation, namely erythema. And it's important to note if the patient is non-lactating or lactating, being within 3 months of childbirth, because the latter is associated with better outcomes. Now, obviously, with any fluctuant masses, there would be concern for abscess. And so ultrasound would be the first-line imaging modality to further evaluate. Mastitis would present with tissue heterogeneity, as well as dilated ducts under the regions of concern. In terms of abscess, we would expect to see a fluid collection. Risk factors associated with a higher risk of infection include diabetes, steroid use, as well as obesity. In terms of the treatment for infection, for mastitis typically can be treated with oral antibiotics. However, if there is more severe infection, such as an abscess, then that would require drainage. And so this would be performed with a 16 or 18 gauge needle with saline flushes through our aspiration until clear. 1 gram of cephedrine or 40 to 160 milligrams of gentamicin antibiotics can be given, especially if the abscesses are larger than 3 centimeters. It's important to note when advising these patients that these procedures tend to take more than one go in order to have resolution of the abscess, an average of two for abscesses less than 3 centimeters, and about 3 to 4 times for abscesses greater than 3 centimeters. The success rate is pretty good, 54 to 100%, and it's improved for abscesses less than 3 centimeters and for patients who are lactating. Typically, follow-up ultrasound is performed 7 to 14 days after aspiration. Now, if aspiration is performed up to 5 times and the patient is still having refractory abscess, then catheter placement should be considered. And this is typically done with a 6 to 8 French catheter. This would be flushed 3 to 4 times daily with saline and removed once there is minimal output, less than 4 milliliters, and the cavity is no longer visible under ultrasound. This next patient had a well-circumscribed hypoechoic mass in her breast, which was highly suspicious for a galactocele. The patient was insistent on a biopsy, so it was performed, as you can see here. 2 weeks post-biopsy, the patient noted lactiferous discharge, and the ultrasound showed a milk fistula. This was managed conservatively, and 6 weeks, there is a small residual galactocele. So we'll discuss milk fistula, the risk factors, treatment approaches, and prevention. So milk fistulas are overall rare. Their presentation, as our patient, is lactiferous discharge at the needle insertion site. And the risk factors are going to be patients who are lactating and breastfeeding. And this will present typically several days after the biopsy. In terms of the natural history, spontaneous closure can take several weeks, and this will be important when we discuss this with our patients. In terms of the treatment, conservative management is most commonly performed, and two different approaches can be done. The first one more common than the second. The first one is drainage, where we place a colostomy bag or dressing over the site of lactiferous discharge with cessation of breastfeeding. And another approach described in the literature is essentially diversion, where we apply a pressure bandage over the biopsy needle site with an increase in frequency of breastfeeding. Now, bromocriptine therapy can be considered to suppress lactation for 2 weeks, but keeping in mind that this can result in cardiovascular side effects, and then surgical correction if the above techniques don't work. In terms of the prevention, fine needle aspiration can be considered for suspicious masses in lactating women. Next, we'll discuss implant rupture and how to prevent that. So there are 4 main ways, 4 main prevention techniques. The first is to consider our approach for any masses that are close to implants. And taking a more parallel approach as opposed to a steeper approach can prevent any steeper angle and penetration of that implant. Also considering the biopsy device, using a non-throw biopsy or fine needle aspiration, we are able to visualize where the tip is, and as opposed to a throw biopsy, during the biopsy for a non-throw device, the device will not extend past our visualized tip into an area which we wouldn't want it to go, such as an implant. And an important technique to also note is positioning. Now, it's just been described in the literature to displace with tape any retropectoral implants away from the lesion. So here we see that the lesion is inferiorly, whereas the breast is displaced with tape more superiorly. And before and after, we see that the distance between the lesion and the breast implant has significantly increased, allowing for a safer margin for our core needle biopsy. And the other consideration is hydrodissection, so instilling local anesthetic or sterile saline under the lesion to create more safety zone. So here are some examples. So here is a mass that is close to an implant. And here the authors of this paper were hydrodissecting with their local anesthetic, creating more of a safety margin between the implant noted by the asterisk and the lesion noted by the black arrows. And here a fine needle aspiration technique was employed, taking also a more parallel approach into the target lesion. This next case is a patient who presented with shortness of breath during a post-biopsy mammogram. So a chest radiograph was ordered, and on this chest radiograph it was noted a trace pneumothorax with follow-up showing increase in size of the pneumothorax, which was subsequently managed with a chest tube. So we'll discuss pneumothorax, the risk factors, prevention, and treatment. So post-core needle biopsy pneumothorax is rare. They're actually limited to just case reports and literature from fine needle aspirations, and it's been reported only 0.01% of the time. Patients will present with dyspnea, and potential risk factors, as noted in the literature, are going to be in patients with Poland syndrome, where they have an absent pectoralis muscle, such as shown here on these MLO views. Here we see the pectoralis muscle nicely, and on the contralateral side, it is not there. So it decreases the distance between the pleura and the lung, as well as the potential target lesion. So Poland syndrome being a potential risk factor, the technique and or level of training has been described, and also not using ultrasound guidance. So in order to prevent this, of course, using image guidance, as well as using a trajectory as parallel as possible to the chest wall if there is a more posteriorly located lesion. And again, similar to preventing implant ruptures using a non-throw biopsy device if the lesion is in a precarious position. In terms of the management, further work of the chest radiograph, placing the patients on supplemental O2, as well as performing needle thoracostomy and chest tube if necessary. So here is a summary of the severe complications that we have discussed that can occur after core needle biopsies. So to review, hematoma. This is often seen in post-biopsy imaging, but this is rare to be clinically significant. Patients can continue their antithrombotic therapy, keeping in mind that per SIR guidelines, an INR goal of less than 2 to 3 and platelet goals of greater than 20,000 if indicated in these patients. Pseudoaneurysm formation is also rare. We see this as to and fro waveform on ultrasound. This is treated with pressure compression or ultrasound targeted pressure at the pseudoaneurysm neck. And if thrombin injection or alcohol injection is to be considered, this is to be performed away from the pseudoaneurysm neck to prevent systemic circulation of thrombin or alcohol. Infection, again, also rare. Most can be managed with oral antibiotics. And if an abscess is seen on ultrasound, then multiple aspirations can be performed. Milk fistula, again, also rare, but should be mentioned during the consent process when patients who are lactating undergo biopsy. And these, for the most part, can be managed conservatively. Implant rupture, the key to prevent this is technique. So using a parallel approach, adequately displacing the implant, and also consideration of hydrodissection and non-thorough device or fine needle aspiration for lesions that are close to the implant. And in terms of pneumothorax, if the lesions are more posterior in location, then we can employ similar techniques that we would for preventing implant rupture. And that includes taking a more parallel approach and considering a non-thorough device. So I also wanted to give some acknowledgments to the amazing breast radiology attendings that I work with at UC San Diego. Dr. Ojeda Fournier, who's the director of our breast imaging facility, Dr. Chong, who is the assistant program director of the diagnostic radiology program, and Dr. Egdatari, who took a lot of time to train me and teach me how to do breast biopsies. So thank you everyone for your time. If you have any questions or comments, I'd be more than happy to answer them. My email is jdoe@ucsd.edu.